Hello everyone and welcome to our module on the hip. The hip joint is formed between the head of the femur bone in the leg and the acetabulum of the pelvis. This is a drawing of the pelvis on the top right side of the screen. The acetabulum is shown here. It's the socket into which the head of the femur fits to form the hip joint. And the hip joint can perform all the usual movements of ball and socket joints, including all of these maneuvers I've shown on the screen here. Now what's confusing about the hip joint is that there are lots of different muscles and many of them work together to perform these movements. What I'll try to point out to you in the next few slides is the fact that for each movement, for example abduction or adduction, there's usually one primary muscle or one or two primary muscles that carries out that maneuver, and that's what you really want to remember for the Step 1 exam. The major flexors of the hip joint are shown on the slide here, and the one that you definitely want to remember is the iliopsoas muscle. In the pelvis, there are two muscles, the iliacus and the psoas major, and they come together to connect to the hip and form a single structure called the iliopsoas muscle. And this muscle is the major hip flexor and the one that you definitely want to remember. Some other hip flexors I've also shown on the screen here. They include the tensor fasciae latae, the sartorius, and the pectineus, but definitely the iliopsoas is the one that you want to remember. The major extensors of the hip are the gluteus maximus and the hamstrings. Shown on the screen here is a drawing of the muscles at the back of the leg and hip. The largest muscle in the buttocks is the gluteus maximus. That's why it's called maximus, and it's one of your major hip extensors. The other group of hip extensors are the hamstrings. There are three muscles that are found in the back of the thigh. Those three muscles are the semimembranosus, the semitendinosus, and the biceps femoris. And the job of the hamstrings is to flex the knee and also extend the hip. So working together, the gluteus maximus and the hamstrings are the major hip extensors. Abduction or abduction means movement away from midline. Shown in the drawing on the top right side of the screen is a man who is abducting his hips. Maybe you've done this exercise at the gym. And the major hip abductors are the other two muscles found in the buttocks, the gluteus medius and minimus. There are drawings of these muscles on the screen here, and they are the major hip abductors. Adduction or adduction is movement toward the midline, and most of the hip adductors have the word adductor in their name. That's very helpful. So for example, the adductor magnus muscle is a hip adductor, so is the adductor longus and brevis. If you look at this drawing on the screen here, the adductor longus is shown here, the magnus is down here at the bottom, and the adductor brevis is shown right here. There are also some other hip adductors that don't have the word adductor in their name. For example, the pectineus plays a role, and so does the gracilis. But if you mostly just remember that muscles near the hip with the word adductor in them are the adductors, you can usually answer most Step 1 board questions. In external rotation of the hip, the knee moves away from midline and the foot moves toward the midline. This is often tested clinically by having the patient lie on their back. For example, if this is the head of the patient, they're lying on their back. The patient then flexes at the hip so that the legs are going upward, and the patient also flexes at the knee so that the knees are going outward. In this position, if the examiner pushes the knee away from midline and pulls the foot towards midline, that is testing external rotation. This is carried out by the gluteus maximus. This is also one of its roles. And in addition, there are several smaller muscles called external rotators. These include the obturator internus, two gemellus muscles called the superior and inferior, and the quadratus femoris. These muscles are all shown in this picture on the screen here. This is the obturator internus. The quadratus femoris is here. And there are two gemellus muscles. One is the superior and the other is the inferior. Internal rotation is the opposite of external rotation. In this movement, the knee moves toward the midline and the foot moves away from midline. There are no muscles that are considered primary or major internal rotator muscles. This is a motion that is done by a number of smaller muscles working together. I've listed some of the many muscles that contribute to internal rotation on the slide here. This includes the smaller gluteus muscles, the tensor fasciae latae, a couple of the adductor muscles. Also, one of the heads of the adductor magnus contributes to this, and finally the pectineus. On the Step 1 exam, they've moved away from strict memorization questions such as which of the following muscles externally rotates the hip. What they are more likely to present you with are clinical scenarios where a nerve to one of the hip muscles is damaged, so let's talk about those now. And we'll start by talking about the superior gluteal nerve. This nerve derives from the sacral plexus at the level L4 to S1, and it is a purely motor nerve. It has no sensory role. And it's got the word gluteal in its name, so that can remind you that it innervates some of the muscles of the buttocks. In this case, it innervates the gluteus minimus and medius, which, as I just told you, are major abductors. It also innervates the tensor fasciae latae, which is a flexor. So you can imagine that patients with superior gluteal nerve lesions are going to have difficulty abducting the hip and also some difficulty flexing the hip. The way this nerve is often damaged is by intramuscular injection into the buttocks. If you look at this picture on the screen here, In the lower quadrants of the buttocks, this is where you can find the sciatic nerve. It's a large nerve that runs down into the leg, so you never want to inject in the lower quadrants of the buttocks. In the upper quadrant, in the medial portion right here, is where you find the superior gluteal nerve. So if you inject in the upper medial portion, you can damage this nerve. The upper outer quadrant is the preferred area to inject because usually you won't damage the superior gluteal or the sciatic nerve. If you do inject in the wrong quadrant and the superior gluteal nerve is damaged, this will present in the patient as weakness on hip abduction. And what they'll often complain about is difficulty walking because you need your abductors of the hip to walk normally. And the classic finding on physical exam is called Trendelenburg sign. I'll show you a picture of this in a minute. This is when the pelvis tilts with walking because the weight-bearing leg cannot maintain balance because the weight-bearing leg has difficulty with hip abduction. It's a classic finding in superior gluteal nerve injury and problems with abduction of the hip. Shown on the screen is a drawing of Trendelenburg sign or gait. So in the picture on the right side of the screen here, when this woman bears weight on her left leg, her pelvis is straight, and that's the normal situation, and this means that the hip abductors are working. In the picture on the right side of the screen, when this woman bears weight on her left leg, her pelvis tilts, and the reason it tilts is because she has weak abduction. This is a classic sign seen in any cause of weak hip abduction, including lesions of the superior gluteal nerve. It's also seen in some other hip disorders, but what you want to remember is that this means there's a problem with abduction of the hip. The inferior gluteal nerve also has the word gluteal in its name, so that can remind you that it innervates a gluteus muscle. In this case, it's the gluteus maximus. Injury to this nerve is rare, but it can happen because of pelvic masses, and when this occurs, patients have weakness with hip extension because, as I told you before, the gluteus maximus is the major hip extender. The way this often manifests clinically is that the patient will have difficulty standing from a sitting position. Anytime you stand, you need to extend your hip, and that's difficult if you have weakness of the gluteus maximus. I'll finish this video by talking about a couple of hip disorders that don't involve the musculature of the hip, and we'll start with avascular necrosis, which is also called osteonecrosis. This is a condition where there is compromise of the blood vessels to the bones. That's why it's called avascular, and it leads to necrosis of bone tissue. And it can occur in lots of different sites in the body, but it's very common at the femoral head. And when the femoral head loses its blood supply and develops avascular necrosis, this will lead to groin pain. That's the most common complaint. It can also lead to pain in the thigh or buttocks area, and importantly, the patient will have difficulty weight bearing or moving their hip on physical exam. The easiest cause of avascular necrosis to get your mind around is trauma. If there is a fracture to the femoral neck, this can cut off the blood supply and lead to avascular necrosis. And what you want to remember about the blood supply to the femoral neck for your step 1 exam is that the major blood supply is via the medial circumflex femoral artery. If you look at this drawing on the screen here, this large blood vessel here is the common femoral, and it gives off a deep branch called the femoral profunda. The femoral profunda gives off a branch called the medial circumflex artery, and this is what delivers the blood supply to the neck of the femur. So if there's damage to the medial circumflex artery as a result of trauma, this can lead to avascular necrosis of the femoral neck. What's confusing about avascular necrosis of the hip is that there are many non-traumatic causes. The exact mechanism of these causes is usually not well understood, but all the things listed on this slide here are associated with avascular necrosis of the hip. The most important one to remember is glucocorticoid or steroid therapy. So people taking steroids for inflammatory conditions like rheumatoid arthritis often develop avascular necrosis of the hip. The mechanism of this is not well understood, but it's one of the most feared side effects of long-term steroid administration. Patients who have lupus are also at increased risk for avascular necrosis, and they sort of have a double whammy because they often require steroid therapy for their lupus, and then the lupus itself places them at increased risk of avascular necrosis. Heavy alcohol consumption among alcoholics is associated with avascular necrosis. So is sickle cell anemia, and so is Gaucher disease, which is a lysosomal storage disease that I talk about in the biochemistry section. Slipped capital femoral epiphysis is usually called a SCFE. This is a condition that happens in children. It's a fracture through the growth plate and involves slippage of the femur overlying the growth plate. If you look at this picture on the screen here, this is the growth plate, and the femur above the growth plate has slipped. That's called a SCFE. It's the most common hip disorder in adolescence. It usually occurs in children 12 to 14 years of age. They present with groin pain on the affected side. If untreated, this condition can lead to avascular necrosis, and it's usually diagnosed by X-ray like this one shown on the screen here. I'll finish with Legg-Calvé-Perthes disease, which most people just call Perthes disease. This condition also occurs in children, and this condition is a form of idiopathic avascular necrosis. Basically, for reasons that are poorly understood, some children, usually 4 to 8 years of age, develop avascular necrosis with no obvious trauma or other secondary cause. For reasons that are poorly understood, these children have abnormal blood flow to the femoral head, and that leads to avascular necrosis. It presents as hip pain and limping in a child, and it's diagnosed by X-ray. If you look on the screen here, this hip joint on the left side is deformed, and that's because it's got an abnormal blood flow, and there is osteonecrosis or avascular necrosis occurring in this child. And that concludes our video on the hip.